Hi, this is Walt Medlin of the Bariatric Medicine Institute, and I'm here just to do a brief overview of our information session, sort of an executive summary. It'll still take a little while, but hopefully it'll be a guide that you can refer back to and then take more deep dives into other areas. So I'm just here recording in front of some show and tell stuff, but I'm going to give you brief intro first about just obesity and what we mean by weight loss surgery or metabolic surgery. Obesity is misunderstood in a lot of ways to just be a disease of overeating or under exercising. It is true that physics works, that you can't put on weight without having excess calories, but the control mechanisms in our body to cause us to be more hungry or to cause us to conserve calories in times of perceived starvation are incredibly complicated. And you probably heard a lot of those on the news with ghrelin and leptin and PYY, peptide YY or GLP-1, a lot of medications that can impact either appetite or impact metabolism. Different foods have some effects. But one of the biggest impacts is actually just the genes that we are born with do have people are born with different levels of hunger, and in certain situations that can be adaptive or maladaptive. It can be great for preventing starvation or death from starvation when there is no food, but it can also be maladaptive or dangerous when in a time of excess causes you to not have your appetite go down when your weight is high enough already. And that really is the baseline of a lot of this. We are, as a world, not just Americans, but as a world, we are generally under-exercised in the 21st century. We are generally overfed, except in areas of mainly warfare, where there's real starvation, and famine is usually treatable as long as there's not a war preventing food from getting distributed. So when we talk about obesity in the first world, in the United States, even among poor people in the first world, for the most part, there is an excess of calories available. They're fairly inexpensive, they're subsidized, and we have a lot of energy-saving technologies, so we don't automatically burn as much energy. Different people, though, are susceptible to obesity as a side effect of this, and so not everybody gains weight. But about 30% of Americans are now, 1/3 of Americans are now classified as obese, which is a body mass index of greater than 30. I'm not going to go into BMI too much today, but it's basically a relationship between your height and your weight. It's not a perfect measure, but it is a good surveillance tool for looking at whole populations of people. Unfortunately, we do use it for individuals as well, and that's not always appropriate. I think we do need to we know that we need to individualize beyond that. So, is there anything specifically wrong with being heavy? And the answer again is complicated. If there's one thing I can say here, you're not going to get totally simple answers, but we do have some things that we know work or are helpful. There's not a cure for what we call obesity and obesity-related diseases, but it doesn't mean that they're not treatable. So we have treatments and they are effective. They're not cures. But obesity generally is dangerous. Even if it's not making you sick right now with diabetes or heart disease, it increases your lifelong risk of cancer. It increases your lifelong risk of arthritis and losing your mobility as you age. And it does have social costs as well. And there are a lot of things that are life-threatening, and they grab the headlines. Diabetes, like I said, cancer, heart disease, stroke. Some of the things that aren't life-threatening can still be just as important for quality of life, and that is arthritis, infertility, stress, incontinence, leakage of urine. Headache actually can be related to obesity, sleep apnea that can make people feel like they have very poor energy, in addition to being dangerous too. So again, even these non-life-threatening, attention-grabbing problems can be treated and can be improved, even if people don't have complete resolution of their weight. So I think that's enough of an introduction. There's so much out there, and this is really just to acknowledge some of these important things. Sorry, I got my notes down here. Going forward, talking about what we can do to treat weight, I don't want you necessarily to look at everything as the strongest in terms of the most weight loss or the weakest in terms of not enough weight loss. A lot of people who would be actually pretty happy with some medication related weight loss, sometimes they will talk themselves out of it because it's not as many pounds as they were thinking about losing. The same goes for some of the less invasive operations. I do think any treatment we have has some risk, from aspirin to brain surgery. They all have some degree of risk, and one thing that people make a mistake in sometimes is overestimating the risk of an intervention, or of whether it's a medication or a device or an operation. They tend to overestimate those risks. So we also tend to overestimate what results we're going to get from diet and exercise in terms of weight, but we probably don't appreciate enough how much those can be important for overall quality of life, even if weight doesn't change that much, and how important they are to underlying health as well. Definitely, you're not going to cure diabetes for the most part with simple diet interventions, but you can have much better average blood sugars if you're doing the diet and exercise components of that. And I think also people misunderstand what exercise and quality exercise means. They think about people who are athletes. I always talk about marathoning vegans. You don't have to be perfect to benefit from an active lifestyle, from maintaining muscle mass, which is not necessarily being a bodybuilder. It's actually that as we age beyond our early 20s, we lose about 1% of our muscle volume and our muscle weight per year. If we just stay moderately active, we can sustain most of that muscle. And if you think about people who are fragile and frail, the medical term for it now is sarcopenia, not enough muscle. And those are the people who have the least reserve to fight an injury or a disease. They also are a little more susceptible to other infirmities as they age. So maintaining muscle mass has very little to do with actual overall body weight. You can maintain a lot of muscle mass and be heavy, or you can actually have very low muscle mass and be heavy. And the same thing goes for skinny people. There are some people who are very skinny, but they've still got a fair amount of activity and muscle mass that they're not losing. That helps with bone health, helps with all sorts of immune function for certain things as well. All right. So I'm not going to go through the whole list of related diseases. I've covered the basic intro, but I think, let's see, grabbing my notes here. One other related thing I just want to talk about that people need to talk about with their doc is heartburn and reflux, because we are operating, if we're doing surgery, right in that area. Okay, and these are after surgery things, so I'll talk about that a little later.